Okay. This one is the dependence. I don't know what happened. I came back when the gallery card expired. I don't know. So I've shared the fresh one.
So there will be a lift.
I said when the finish, like it's full.
No. Okay. I hope we are not interfering with the current situation. But you have another one. Can I use that? Can you put, Big Man, can you put that one near them? Connect it like from here.
I'm not any put.
Can you put?
Put it careful. Don't turn off that one.
Okay. Is it on?
Yeah.
Ladies and gentlemen, welcome back from the lunch break. I want to call us to order and welcome back from the EOC launch. And hopefully it was a good experience for us. A few announcements. As we appreciate the different partners who supported this event, quite a number of partners have stood in to make sure this event is a success. And I want to encourage all the participants to make sure you have registered with the registry. There are different forms that have been passing around. There is a form by PMI, Presidential Malaria Initiative. That form is accounting for the food we have eaten. They are paid for a good meal. We had good lunch already. And then we have an attendance sheet that is by UHA. So UHA is will be taking on the meals for tomorrow, and they're also facilitating the meeting. In one or the other one is the travel allowances for the technical team that includes the DHOs, the chief administrative officers, the NDHO, maternal health, the members of the EOC steering committee, the board members of Moroto Regional Referral Hospital, the Regional Referral Hospital team, and Team UHA will be facilitating the travel allowances. That includes fuel and the night allowances. We also want to make it clear that your drivers, the drivers are receiving a full package, including their lunch. And that means they are not part of the lunch that we serve at the hotel, because the drivers are receiving the full payment, including lunch. Yeah, so that is also a clarification. We will not have that repeated tomorrow. Yes, then we have the political class. I say the political class less the members of the steering committee. The steering committee is being facilitated by UHA. So the other political leaders, the LC funds and RRDCs, are being facilitated by Malaria Consortium. And Dr. Odom, right behind there, he will be passing on some forms for the LC5s and the RRDCs in the house. Less the RRDC Cotido and the LC5 KARAMOJA. Those are members of the steering committee facilitated by UHA. The rest of the other technical members from the MOH team, or that is UHA funding that, I know UNFPA had committed money to facilitate the ministers and the MPs, but we've not had them appear even after we made a number of phone calls, so they have not appeared. So, and you have made yourself it. We have a PPH week next week, but we also have a toll-free. We may make sure the toll-free packages. Dr. Charles, need to confirm whether we have the money for the toll-free line for EMS before UNFPA takes back their money. Yeah, we need to confirm that.
Okay.
We need to utilize the EOC had funding gap. So, this is the only opportunity we have to. After here, they will say, we don't have money. So, it's like if someone is you cannot go and collect money after you had the wedding. We want to appreciate UNICEF. There are more packages. We're doing very nice name tags, and we have more materials. We'll be sending you those other materials, the launch books and many other operational manuals. UNICEF is printing them, and we'll be looking forward to having them reach out to the different stakeholders. We enjoyed those nice notebooks that you see around this time, and there are more things. We have a very beautiful afternoon, so I want you to listen and listen in very carefully. And when you look at the programs, the other earlier joint review missions, we have not recognized best performing districts and key stakeholders, but this time we are rewarding, and we have used our good electoral commission without bias. The electoral commission is very good that are reviewed, and we will show transparency here. There is no machine that did a lot of things. So we will show you how we will have to reward best performing districts across a number of categories. And I don't want to preempt that session, but that will come after we have looked at the performance of the region, and then we'll also recognize best performers within the KARAMOJA region. And I know we are here, the commissioner and the top management, MOH, will give this award this afternoon. As we shift in towards that, we have, I want to just give a few minutes to Dr. Charles. Dr. Charles, that was the only session that was remaining. So I want to invite you so that you give us a brief snapshot of the EOC journey, but it should be, it's going to take very short, since we already into the time of other programs. So all the speakers, we expect you to time has been there. We have SCAP department on this strengthening health service delivery systems in Uganda. Web SCAP? Okay, we'll confirm that. Okay. So we have then the 8 more. I know Dr. Char will be getting ready to tell us, to give us the journey of 8 memo as of how we've progressed the last 2 years and what we've attained. And then definitely we want to look at the performance. So Dr. Charles, as that is happening, as soon as I finish up my session, I'll be handing over to RDC Abib, who will be chairing the next afternoon. Yes, as soon as we finish, the RDC Abib will be taking over the chair. Thank you so much. Thank you. You're welcome, Dr. Charles.
Good afternoon, members. All members are all protocol observed. I would like to thank Dr. Brian Okot for what he has been doing since morning. To work. We are very grateful for that, Dr. Brian. Charles Wandui, I'm the head of Public Health Department, Moroto RRH Hospital. I'm also the manager of the KARAMOJA Public Health Emergencies Operations Center. I'm also several other positions, including regional coordinator for and immunization. So there are several. So today I will be that as PHEOC manager and head of community health. Remember, we started as a Moroto PHEOC, but later we changed to KARAMOJA Public Health Emergencies Center. So in some of you, like most stakeholders, like those who attended the stakeholders meeting, you might have got that correspondence. So when you hear now KARAMOJA EOC, I just want to tell you that it's the same. It's now no longer Moroto, it's now KARAMOJA. So it's now that, and I would like to inform members that the EOC belongs to the regional steering committee. They are the ones who provide the strategic leadership and we work for them. They have been introduced by the director, but I will also that we have the director himself with the chair, UPDF commander, the deputy chair, the chair of the DHOs is the secretary, then we have the chief whip of RDCs, we have chair, administrative officers, district councils, council chairs, we have police commanders, Moroto and Depot, WHO, Food Agriculture Organization, chair, DVOs, and this is what received when the chair DVO was pulled from ex-official now is officially the member of the EOC. Then you can see how I squeezed in myself there. And so I work for the DHO with the secretary of the committee. And it was approved because they realized instead of me preparing reports for the secretary to present to the steering committee, they said, look, I think you just come and report verbally. So I'm grateful for that opportunity that was granted. So that is EOC at the strategic level. Like we said before, the physical address where we have been launching is not only the EOC. We can work from anywhere, virtually, anywhere. That is for location, special room, you can sit there, but that doesn't stop us from functioning. Like we said, there's a hub, it's simply a hub, it's a nerve center for coordinating information and resources. That is all. That is all. Something will happen for DHO, something happen in your district in the health center, too, you will not be aware of it. It has been reported through M-Track. It is very hard for the district to review these things every week. But we do that. So you get a call from us that you have a suspected case somewhere in your hospital and you wouldn't. You shouldn't be surprised because that's what we do. And so if we have any if we have anything happening in the region, the EOC is supposed to know. And doing all that, we are working with a catchment population, 1.2 million people across the 9 district local governments. Now, after the strategic leadership, we also have our leadership at the EOC, where I'm the manager. We have the administrator who runs the daily operations of the EOC, making that everyone else is working comfortably. Then we have senior M1E, senior medical records. I've introduced them before. Senior M1E, I don't know if she has come. Vicky Acho, she's there. So that is our senior M1E, who is taking charge of operations. And then by statistician, ICT, public health nurse, there she was instead commander, she's still instead commander. We have a laboratory technology who is a local person for Moroto district, also works for us in the surveillance, with us in surveillance pillar, and WHO representative who usually sits with us and works with us every week we're together, we write together. So I would like to tell you the story of this journey, which starts back in December 2022. Started with the benchmarking. Our hospital director sent us benchmarking. The EOC, as mentioned, they are the first EOC to be set up in Uganda. After it did very well, they thought they should also expand to other regions. So the director sent us to Bali for benchmarking in December. And immediately we came back, we did the needs assessment, we did what hazard, also risk assessment. But then during that time, we had funding issues. There was the KARAMOJA North and the South, and that divide gave us a lot of problems because that time it was CDC funded projects down south, and they couldn't get money in time. So we ended up having only the Northern KARAMOJA assessed. So after that, we went for regional stakeholders meeting, which was held outside there in the tent. That is then back in March 2023. Then it was that time, our community came down from the national EOC and assessed us. And we landed flat. So we failed. It could not let us launch because we were short of very many things, major equipment. So from that was July when we failed the test. July up to December, we came back. Right still had left us. The exam in the Hampo, they didn't abandon us, but they left. So we offered until we got a new uncle called the UHA. When this uncle comes back in December, he says, you people, there's something here small. We can invite these people, they come back. But this time, Uncle Milton said, you people, I am tired of you failing. So I'm coming first to help you prepare coach. So they came and coached us for 3 days. After coaching us, that is the pre-launch preparation. After that, then he turned around on the 4th day, assessed us, and we passed with the flying colors. But of course, what was being passed cheating was the UHA was pushing in some equipment, what, so we can't ticking boxes, we can't do what, painting what. So we passed. After passing the test, they said, now what is left with you? The most important thing is you should have parents. That's when the steering committee takes shape. And they came back and they again our commission and team and they inducted the steering committee. So they are now we're beginning to breathe. But we said now, before we take full wings, we have to start walking and maybe running. We started the epibulating. Writing, and we started first without that. Someone came and helped us, tried to acknowledge the help she put in. At that time, we tried to work on employment to recruit, but it didn't work out. So that person left. So we turned around and said, okay, now we don't have an expert work with us. We set up a committee. We said, collectively, we cannot fail. So we put together a committee, and that's the epibulating committee. It is the only KARAMOJA regional, KARAMOJA Public Health Emergencies Operation that has an epibulating committee. And this is where the team, EOC team, has teamed up with the stakeholders. And that has given us a lot of credit because what we consume is chewed off the pan and didn't even get on the table. Because the same people are working with us who are a select group of experts from the region, across the region. They make it very interesting cookie. So off the pan, people just pick from. And that's how our epibulating is selling. Because it is just many hands cooking it. So that is it, and I would like to take you through some of the activities we are doing. We do data analysis, like I mentioned, we analyze data, we are the nerve center. Without data, we are not working at all. So we analyze data and we report. And we report, the main way we report every week is the epibulating. Then we also do reports through, do sport reps. Something happens, you write. Later they say it was true, we say okay. But we have written, we say the sport rep, it entertains all those rumors. When it's confirmed now, we sit down and write a situation report. And the state commander for measles can tell you that she writes every evening she writes. Situation reports come every day. So we do a lot of writing, analyzing and writing, collects that information, process it, analyze it as reports every evening. But by mornings on the desk of the National EOC and Ministry of Health. Then we also do monitoring and surveillance. We do what we call watching. Watching is like peacetime. We watch, we listen, we entertain all the rumors, all the signals coming in, something has happened, we listen to that. We don't have other technology to help us like toll free and what, but people call us from the district, they call like that. So that's what we do. Even when there's an outbreak response going on, we still have people watching. The duty people, officers are there. That's why I tell you the chairboard, also duty officer has captured signals. So, and also do active search. If we hear something, we can do active search and verify quickly, say register and things like that. Then also do coordination and communication. Coordination, again, we are working on information. We are looking at resources. We are communicating with the communities. We are in touch of district task forces, stakeholders, something has happened, we get in touch with them. We have, as I was saying, we are spread, so far we have actively engaged with four districts, the different outbreaks that have occurred. Then operational support, we work with the district task forces. The other time we oriented the last month, we oriented the and mortality district task forces. We are short of funds, but we should go on and oriented other districts task forces that they are in the know. And actually, talk of the task forces, I would like to acknowledge what the RDCs do. It's a lot of work. Actually, RDCs were thinking, one of these days we have to put them aside for training, serious training in health. Because they do a lot, chairing those task force meetings and handling that information, because that's what again they do there, handling information, organizing things. The good thing is also, which makes them useful, they have a lot of resources at hand. So I'd like to acknowledge their efforts and just to finally relate that we're involved in the business of prevention, detection, and responses. And all this we use information, coordination, information, resources. Thank you. So, what do we do when it comes to epidemiology? How do we analyze and report our data? Like I mentioned, we have the epidemiological bulletin committee. From there, we have a editorial team, which appears on the bulletin. And chiefly, the sources of data we are using here is the indicator-based surveillance. This is the data which is entered from the facilities. Then it is put together. We use that data, analyze it, and come out with the findings. Then they also use the other arm of event-based surveillance. We have been very, very poor in event-based surveillance until recently. The same arm when we came, they trained us, and immediately after the training, actually the following week, the district focal person called to say we have cassava poisoning here. That was the following week. Cassava poisoning in Loctare. So that is an event-based surveillance. And that's what we're encouraging. That's the other arm. I'm about to get to our strong point. But we need to be, it's like having a very strong right. Mark this one. Event-based surveillance. It's beginning to come. We're getting reports of there's been poisoning of fish in a facility where we lost 4 people. That is still event-based surveillance. There's an accident. There is even the cattle rate. I think tomorrow we shall dwell more on that because it involves very many things. It breaches very many boundaries in health and jurisdictions, moving hearts, and which involves also injuries and loss of lives. So those are all event-based surveillance. Fires, drowning, flooding, all those are events. We need that, all those things to be. So, reporting rates. is our strong arm. The director mentioned this, I will repeat this, and I came back with the table to add a voice to what he said. Our bragging rights, our credibility of our bulletin. So that bulletin we send you is very, very credible because we are on average running at 94.5% reporting rate. Well above, we have our own targets now. And what we are doing, if you find something in our bulletins, we are hitting at the people who are down on timeliness. And timeliness, we're talking of that one shows timeliness. Here. You see, these were very bad weeks, week 3 to 6, 4 to 6, were very bad weeks. Timeliness went down with the reporting rate of completeness, but a very bad time. But after that, we kicked back. But when you see that line where those bars are completed, they are the reporting rate. We are all through. You should even see what happened last year. We are always up there. So when we tell you that there is brucellosis in Cotillo, and it is very high, we mean it, because for most of the time, most of our centers are reporting. That is how credible it is. But then we delay. Again, we dropped, if you see that curve, we dropped again in week 14. We dropped in time that people were delaying. But sincerely, imagine the situation that they are working. Very poor, you have seen calls when you are traveling. Now, someone says, I'm in KARAMOJA, my network is bad. But they are using that network to send those reports. They are using that network to send those reports. There are stories where people have to fight crime, some high point, and that's where someone has to go to send the M truck, then it comes down. So the conditions we're working in, and the results as you can see, just give those workers the credit they deserve. If you get our report, it is a very, very credible report, it's very genuine. So we go on, of course, we make weekly publications every week we make. Our committee is confident on that. And we have come up with a dissemination strategy. And the other day, director was adding me another tip which we are taking on. We distribute to all the district leaders. The only problem we have is the culture, they keep transferring them. So we build a database, they go, we find it hard to follow up. But other pieces have, I think we will reaching you. So we did say that thing weekly, so that even people, these task forces are informed of what's going on in their districts. And we're going to write again a district specific information sheets to advise and have what put on the district notice boards. Another strategy which I was saying the director was telling me about is we work with the media, and I want to tell the media that we are working with you today, and it's a big start, and we're going to continue. We're going to continue every week. We're going to be giving information every week, highlight what is happening in the region. So that is the strategy. There is even more. We have a whole concept built for dissemination strategy that with the time we shall have published also. So to summarize on this page, I would like to say that all this data is for health action. If it is not for action, then it is not any useful to us. We shouldn't even bother to start. What we aim is for health action. Now, talking of action, these are the districts we have worked with so far recently. In outbreaks, we have worked with AMDAT, we're still working with AMDAT. It is still ongoing. That we need to do the action review. We want to find out why that outbreak still keeps motoring on and on and on. So we were looking for funds to do that review. We need to review the response in Muda. Where have we gone wrong? And there are many stakeholders in this play. So we can't say we're only going to ask the rapid response team only. There are many stakeholders in the play. So we need to review. Anthrax is going too far, too long. Moroto measles is still dragging. We did the early action review. We have issues which we are trying to fix. We also want to go in and do an intra-action review. Then potato food poisoning, this is like I told you, the left arm is already picking up. Even the surveillance reports are coming in. So that was reported. They went in, we didn't even go there. They went in, they sorted it out, it's resolved. We are waiting to write for publication. Then in availability, 4 cases, it was a very unfortunate story. That fish, when they made that meal, all those who ate died. The only family member who survived, she doesn't eat fish from childhood, so she's the only one who survived. So after 2 days waiting, they see this girl comes out, she has been crying in there, hungry, and find out that the parents are dead, and one sibling, then the other was went to the hospital but died 3 days later. So all the 4 dead. We are still investigating. We don't know whether it is the fish itself or someone food poison in their food. We are waiting for analytical lab to do that. But otherwise, for cyanide, was confirmed that the cassava, that the cassava had cyanide. The cassava normally has cyanide in it, but in low amounts. This one in potato had high levels. One died, the other survived. 15. So that is what we have done so far. The map shows that this is where we worked with those teams. So our challenges, human resource, we were missing a key person, the epidemiologist. The second challenge is community. We need the community. If we have the community, we shall have the other side of surveillance. Even the surveillance are working. We need to sit there, and our toll-free line is working, and calls are coming. There's a fire here, there's flooding here. Someone is behaving in a very unusual manner. He's not drunk. Is a broccoli, but the man is, we need those things. We need the rumors. And to get those rumors, we need the community up. So we need to build the capacity for the community. Then the other thing which is still challenging us is the technology, like I mentioned, the toll-free, we're still struggling with that. But the good thing, Dr. Okot has said, the money is in the air. So I'm not talking about funding. We don't have funding problems right now. That's my disclaimer. Those are our issues. Thank you very much. Thank you very much.
Thank you, Dr. Charles. He's saying you don't have running challenges because he knows the money you have. So it has to be approved. Because of levels of approval. I was advocating from the podium here, so we've not yet made a difference to UNFPA for that $1. So Sister, I know Harriet is telling us that there is no gap, so it means she's guaranteeing approval. Also, we have a chair around. You see the big bosses are seated. When you see them around, just know any decision can be made in this meeting. Ladies and gentlemen, we do not have much of time. I want to hand over the session to the next session chair, and that is the RBC Abim. He's already seated. As we have that, we have the next aid memo that will be presented by the lead DHOs. Dr. Char will take us through the next session. We want to run through the next sessions quite fast, and I believe we will keep time. Just bear with us. We had some time lag. Definitely, we will see how to drive the agenda. Chap. Thank you so much. Over to you, RBC.
I think Doctor deserves another clap. Thank you, members. Allow me to welcome you back from lunch session. Lunch was good. I hope everybody had lunch. Is that okay? We thank the doctor for that. Allow me to welcome you back from Moroto General Hospital for the launch of the KARAMOJA Emergency Operations Center that was officiated by the official from the Ministry of Health. I would like to request the Commission to raise up for one comment. That commissioner at one time was the DHO Bali when I was the RDC Bali. And thank you for that. Yes. Thank you, Doctor, for being with us. We thank and appreciate for your support and request that you further support us to build capacities of our sector. Members, it's an afternoon, it's a hot session, you are feeling it. I would request the hotel maybe work on the SC system, but it was very hot, especially my friends who are in suits, you are feeling it very difficult now. Members, as well for this session, I would request that we be mindful of the time. Time is to brief. But for us who are listening, I request that also give time to the presenters. I request that we settle for 30 minutes without movements. We give the presentation for us. And for your opponents, maintain the silent mode, but the presenters can make the presentation. Allow me to now invite the presenter of research on strengthening of health service delivery system. Okay, let me by the presenter give us the presentation. We are still going to the next one, which is the overview of the presentation previous in the month, which is going to be presented by the DHO Otito, with the chairperson of DHOs in the KARAMOJA sub-region. Doctor, welcome.
This modern technology here. The same technology is so good afternoon, ladies and gentlemen. In your various capacities, good afternoon, ladies and gentlemen. Dr. This the director of KARAMOJA region and also the secretary of PHEOC. When I got the notification, not invitation, because I am part of this notification from the steering committee, that from the organizing committee that have a session, I asked them, how would you want it done? then they say it was our decision, we shall do it together. Is that clear? Yes. It was our decision, we shall do it together. So, when the recommendation was to have lunch at 2 p.m., so we shall ask, do we have lunch at 2 p.m.? We shall all answer. If you did not have, you say, we didn't have. So that's how I want the session to run. But also be mindful of the guidance from the chair that you need to factor in time. It's not over discuss. So, in that matter, we have had a good lunch. May I recognize the presence of the leaders. RDCs in the house, you stand up and straight. You may not need to sit for so long. Expect 9 of you. How many are there? 3. Let's see 5. Let's see 5. 5.
Are you doing it for him?
How's it going?
Your computer. Maybe I give you the PDF.
PDF. So I showed a PDF. I have the
Ladies and gentlemen,
I show the PDF.
we had
But the typhoid
meeting we had
changes system.
was in Sorority, immediately after COVID, 16 to 17 of November. COVID had just passed. So we were still struggling to bring up service delivery. So we made some resolution. Yeah, IT. And if I can remember, one of them was the leaders said they don't know what happens in health. So here we are together. So that simple recognition also answered that. Because one of the resolutions was we should engage the leader through meetings. So we invite you, and we're about to present our performance. We have 3 RBCs after 9. How many are going to miss? 6. 5 girls. How many will miss? 4. LC5 are how many? 4. 5 will miss. So those 5 next time will say we don't know what next place we are in heaven. Here we are here deliberating issues. And the decision makers, hey, it is not problem. You go to the table. Here we are here deliberating on very critical issues. Even all of us being here. And we are going back to make decisions. It is better to make decisions from a very informed point of view. This is Kenyan called Lumumba here. When I remember his statement saying, when our leaders have reduced meetings to come to open and close, then what? We are then in decision making. So it is, if we invite you, we expect you to come, sit, follow the deliberation, so that next time we do what? To make decisions when we are informed. So, you see A1. Leaders are not well informed on health issues, and yet they have to make decisions. This is what I'm talking about. So the recommendation was to provide leaders with information to allow them be informed. I think this one, that's it here. We have to do this during meetings. So we perform quarterly review meetings, and we invite all the stakeholders. But at times, what we are seeing here is what in and out. So the key indicator performance we don't, our leaders don't. We may need And the other time to say, when we invite you, you sit with. Because that is now where we get the information. So, colleagues in the district, what is the status there? I think we are trying. And DHOs, are we giving, let us be active. Come on, are we giving information? That's number two. Any leader complaining that he or she does not get information on that? Leader, that is simply how we want to run research. The second one, A2, orientation of these leaders, it is almost related to A1. We have a lot of coordination meetings and so on. One good thing, even in our districts, the RDCs are chairpersons of the task force, so the meeting they call themselves. Chaos are chairpersons of the committees, so any health committee, PDSR committee, policy improvement committee, they call. But there also another animal which is there, over delegation. You find the media cow, assistant cow is the one cow, assistant SAS. I know the delegation is good in the news capacity, but you also need to be there. Anyway, this is requesting for hospital. This is another one. Hospital. We did have, we still don't have hospital in Napa, KARAMOJA, Moroto, and Nakapil. The hospital you see in Moroto is a regional referral hospital. It's not for the district. It's for the whole region. So, Commissioner, you are here. There was a statement I read on social media that there are not also the Prime Minister has known and recognized that 86 districts don't have hospitals. So out of the 86, 4 are here in Kenya. They don't have. And even the districts which have hospitals, it is in principle, in theory. They give you hospital status, then they say to work with the resources there. Expectation goes up and nothing. Like me, I got hospital. I God's grace in 2020, stop 2021. The only change which came there is the PhD father, the current and medicine. The rest have remained the same. I have 24 health workers in the hospital, and I have to run the hospital. And that is applicable even to many other colleagues of mine. So, in addition to this, the message we take up there. We thank you for upgrading you as a status, maybe as Center 3, as Center 4, or hospital, but accompany it with resources. And the resources we need is infrastructure, money, salaries, wage bill to recruit. Local government, there's a section. Yeah, I'll talk about that. So, please, the presidential, how that was? Yeah, it was left so far. So, I know the president, there was a presentation on the ruling government manifesto, which is very clear on giving service or service delivery to the people. And it is very clear. Paris is Health Center 2, Sub-County Health Center 3, County Health Center 4, District Hospital. So, we are still waiting for the manifesto, but with the technical team, let us also do our part. Human resource for health section C, wage. Wage is a big issue. It is very surprising that many times they accuse us local government that we don't recruit. I don't know whether the local government, when given away, can refuse deliberately to recruit. No, the weight is not there. Even commissioners, but he is also my own name. Thank you for coming. Let me also welcome you and recognize you. We were in the same squad, I believe. Wait, even before we come to wait, allow me to take a little bit of time here. Even the staff in post, there are some districts struggling to pay staff in post. We struggled for 3 years to keep, except this year we're now okay. I was abused and called all names for what is not my fault. I was sitting with my colleague of Gabon, said they are still in the same boat, but they are paying wage for what? The patient. So even before we talk of recruitment, even the wage for staff in post, there are some districts which don't have that wage. So this is still pushed to the center. So wait for recruitment, everyone knows wages. We need this to fill the post. There are so many stories about recruitment. I hear the ban of recruitment. I hear the facility to wait for validation report. I hear what. So, but the thing is, we are struggling, Commissioner. We are struggling to deliver service. I would expect the hospital with 24 staff to deliver service. And this story we hear from many other places. It is a very, very appalling. But even this 24, I have no doubt. I think I was supposed to perform civilian section. The people who are doing are senior clinical officers who went to school and did medicine. They are not substantially recruited as doctors in the hospital. They are by qualification. Volunteers as medical officers. Substantially, we pay them as clinical officers. You see how painful it is. When we talk about this, the center has not listened. Or they listen, but they pretend not to listen. So it is really very painful. Something needs to be done. Decided to hide themselves. I'm waiting for 1 month when it comes.
Members, let's allow the presentation, then we shall calculate.
We must speak to ourselves and we are not we must speak here also, they are not doctors now. You see the kind of operation in the area. So we do by that, they think we don't do submission. Every September we are making submission. We move to all the offices. C4 still on Wednesday for recruitment. See what I'm talking about. G, equipment. Equipment. And this is more technical. And let us recognize the partners in the house. We clap for them. PHEOC is coming. All the team of you want to clap for you. There's somebody from the big sophisticated equipment we have in the region for you. Let's clap for one. When you hear of the blood in the water, blood in your teeth, where Kwabas has Habib is a Kwaba. So they are just so passionate about ensuring that our mothers and children don't die when they need blood. They injected the resources to open up that blood collection center and our transfusion center. So in terms of equipment, what I'm saying is we rely so much on partners, and they are doing wonders for mission. What government did, they came and did an assessment on RBF, and up to now we have not received those documents. That is our government. They came to did assessment, nothing came. Partners came to did assessment, they brought. Anyway, it is part of government. From the other, okay, gene expert, we are talking about gene expert is being done, but gene expert is a machine which tests for tuberculosis. So we have a lot of gene experts in all the health center government. So it's very accurate, we don't misdiagnose the TB. Oxygen supplies is still a challenge. We need to, we have oxygen plant in water. Yeah, at least it is there. Thanks for COVID, it came around COVID time. The plant was made bigger during COVID, but it is not obvious, but we still need to do. Then the ambulance. Making this a beam and the took were the noise makers for ambulance. Now they are very you go to ambulances under dry land projects. They are not equipped. Okay, there's transport vehicles. So there's a transport vehicle in a patient transport vehicle in Abila 2. But all of us have transport, patient transport vehicle. We have the oldest UAY 273Y. You hear that number. When did that series start? About 2006, I think. That is when one vision got to write that company. We were called with my RDC, after the L'Oreal to Kampala. We hurried, even without eating, no money, since we are going to receive what? Ambulance. Up to now, we have not seen the GA ambulance. So GA county ambulance. So commissioner, we are waiting for ambulance. Otherwise, maybe bad. So the ambulance, some districts have, some districts don't have. Even Moroto has a UAY series, but Moroto is near to the regional referral. Then the functionality of theaters. Before even we reach to functionality, these theaters were built during the time of the health system strengthening project 2, I think, 2004, 2001, 2002 there. So we need to model these theaters. So the ones we are even operating in is because they were built and then called theaters. So we were asking for expedition, constructions, renovation. But this one here, we cannot even do much about it because of what? Funding. But I don't know whether we have skipped the section on infrastructure. If not, we need to smile it in there. But it should be there. Funding. As my leaders, even if we are not seeing it, but it is somewhere there. KARAMOJA region was being fenced wrongly by the commission. They came to continue in 2017. They found the Italian project under KARAMOJA Infrastructure Development Program already on board. And with that, we have not got any development project in the region. Every time they go, yours is a special grant. Yours is a special grant. You wait for the Thailand Corporation. Wait for the Thailand 2018 well, 2019 well, 2020 well, 2021 well, 22, 23, then 24. They say, they have not approved and advertised. They are now filing. Districts have been benefiting from ministerial PhD development grants, ad hoc funding, transitional grant, sector development grant. Not KARAMOJA. Township came, districts benefited, not KARAMOJA. UGIT came, districts benefited, not KARAMOJA, until the last year when the project was ending. Then they gave us 3 facilities. I don't know even what told them to give us. One in Moroto, SN 2 to 3, Otido, SN 2 to 3, Karaya 2 to 3. Obviously, is that fair? Now, last week, allow me and this is we went for land, you get land conferences. They were presenting beneficiary districts under unit. There is no district near from land, actually, with less than 5 facilities upgraded. Commission. UB, Lama, Acholi, West Nile, not less than 5 facilities upgraded under UB. Majority are 7, 8, we have 12. Continue 1. I have the I know before. Continue 1. We have 15. 2. That is under Thailand Corporation, which is coming. So we have been cheated for 7 years. Late coming project, mind you, other development projects are also going in those districts. KARAMOJA continued 1, Kabong 2. I don't know more. So, to government 0. Then they say wait for the Thailand Corporation project. Wait for the Thailand Corporation. What is this? Please, Commission. We need compensation. We need compensation. Next, Prakoma is now in 2 districts, Moroto, 3. Moroto, and MD has finished. So, Rito Blood Bank, the next step is now, we have achieved blood collection center. So now the next stage is what? Blood bank. So we need to keep on advocating. Next. Malnutrition is still a problem. Also, thanks for partners. Is there any dispute regarding the Nutrition Coordination Committee? Because when I know the Prime Minister to streamline this operation. But if there is any dispute regarding the Nutrition Coordination Committee, please invest. I think you are ready to submit names sometimes. Now, the challenge here is the sub-county level, sub-county Nutrition Coordination Committee, which is a problem. Power, this was raised by Moroto Regional Power Hospital, specifically power fluctuation and so on. But even still power in the region is still a problem. It is something which is coming, it is new. But I am not talking like I'm a position, but I am in terms of politics. But this is what is affecting us. We all know this. Power. Continue with not power last year. When I was this year, all of us were born when there was power in those other places. So, but Karamoja people also there. In those days of budgeted tax, they were also paying taxes. So why are we now like this? So the issue of power is we are really relying on what solar. The sun is natural, so you get your solar panel, you put up there, then you get power. But it also has limitations. In security, I don't have any mandate to talk about that. The RBCs were chairperson of security committees are here. So, but from the testimony of the commissioner, I think the security is also now not in other parts of the region is coming down. I'm not saying it is not there, because there are still sporadic cases like Kotido, we still get cases of gunshots and killings and so on. And I think that is all. It is still down. This one here, but I will talk about
That was answering to
the first. So this is now the memo, but we have talked about this. Everyone will finish. Insecurity. Any comment from other business?
Yeah, the first slide, I saw something where from the right hand side of the arena in a few hours.
The first one, the one that was in for 2020.
I would propose not listening now. We cannot correct the image.
It is now here. It is now here. I think it's now here. And this was 2022. So the situation was so the action was we have to need to district task force with stakeholders. So the security issues are not discussed.
What we are saying that alerting the situation is going to good was bad. But currently, the situation has improved and we have peace within the sub-region. And we can be able now to work and business. Though there are some still isolated cases of thefts that also been managed by the UPDF, the police, and us too, under chairpersons of the RDCs. We have greatly improved. We can now deliver some services.
So I hope the next clap for the security team. Partner support. Yeah, we have a partner. We just need to coordinate us. Is there any progress?
I think before the director, the DHOs from the districts, support those maybe could give us a comment on that. Because every district is different from the other.
Then maybe after that, the director can look what? The final comment on it.
One from the south, one from the north, because we have also some kind of different.
Thank you.
Karanga, Karanga. Anything?
Yeah, we have partner support. I think that is one. Seventh, the starting to face the change in utilizing everything. Now, the rest.
The south. Now, you have something to say?
Thank you. I think
we see partner support in the south, we want to appreciate, but the thing that we want to raise is the coordinator with us. We invite them for they not answer the questions that we want to ask. So again, in that, but I think we are seeing that support. We need you to handle it so that we work together. Thank you.
So, okay, is not there. Now, also so have some
we would like to appreciate the presence of the PhDs, but my concern is their strength at the ground should be looked at. They are very good in the ground, in the community. They do very commendable job, but their sustainability should be looked at. Thank you.
That is a good comment. You capture each other airport. At 8 weeks, we will look at the dedicated support. But even the donors are not asked to rely on by $1 per region. So the $1 per region also now for non-south dedicated activities. So I think it is now not a big problem. The BHTs, RBC said, even the previous presentation was about the capacity of the BHTs. So the issue of their incentive. And the commissioner is here. The government wanted to introduce, the community as workers to choose, which is at a higher level than the VSTs. But funding, I think, is still a problem. We piloted in some districts. But even ours, we have over 1,000 VSTs. Locally, we cannot raise funding to give them incentives. So it depends on partners and programs. And also, I've been interacting with other partners and saying, even their funding, project funding is also being cut. Case in point is Malaria Consortium. So the incentive to PhDs, instead of going up, they will come down. Because we never got upward for all of them. Let me take a round of chair now. Yes,
Thank you, Doctor. There is a question of PhDs. The structure of PhDs is a government of Uganda structure. The government can also remunerate PhDs like LC1s. They get 10,000 per month, and they do a lot of work. Is there a possibility of us proposing to government that they absorb them as government of Uganda structure, and they are remunerated at the end of the month, maybe towards the end of the year, they also remunerate like LC1s. Thank you.
Commissioner, you have to insist something about. But if I remember, last time we were launching the community strategy The minister calculated and it became 240 billion shillings. 240 billion shillings. So we said at that time, government picked up the money. But from the experience we had in that note, we had experience from Kenya, Ethiopia, Rwanda, South Africa. You know the Uganda, which is not playing missions. You are right. You know the Uganda, which is not playing missions. So, why do we like good things and the others say?
Doctor, the time you have 5 minutes to conclude.
Okay. Then we have already talked about recruitment. So we shall go see. When first September comes, we submit to where? Positions? Recruitment. So police DHO will go back and notify this provider of ours here that these are the gaps. So going forward, we share that, because we still a body program. Our role as DHO, the SO department, is to notify the county officer. Now we're working with the human resources, that's our mission. And then we follow up. Critical staff still goes to the hospitals. Yes.
On the way, the commissioner comes back. In fact, the government analyzed the way we did for from hospital to one medical center, so that means to commit at least annually, give us some money.
Continually 7.6 billion shillings. Recruitment, using the old structure, not even the new structure. So we now bring in the new structure, then we are finished.
Doctor, when you talk about recruitment for being, we have a hospital. We have currently a commissioner, currently we have only 2 doctors in a big general hospital. I request the DHO, myself and account, we engage the commissioner, maybe in session separate after this. Our situation is worse.
It is worse.
Doctor, continue with some.
Okay, PHEOC capital development we talked about, we need additional. Now, commissioners, if government can give us 1 million, why can't they commit themselves also to? We are 146 districts and municipalities and cities. That is 146 million. I know that number is there. Annually. If it can be given to God, why can't they also give us 1 million? No, we are starting. If it can happen to roads, critical sector, it can also happen to what? It can also happen to health. 1 billion we can do a lot. So, fuel facilities in the district, we have talked about this, but the latest information we got, Commissioner is here, we told there no construction of new facilities. So, policies and some countries with no new facility have to follow Norway, which is another follow. But I have my force is enough for ready, so to strengthen the organization of existing facilities. So, but we continue, we have apprentices, 4, and 6 plus division.
6 support without their facility. Not even the center.
So, continue as 6. Very nice. So, new facilities. Talent operation, we have talked about it. We don't need. So, Commissioner, we need to follow up. Contract have been awarded. I don't know. brother time is better than us. I say we cry, let's cry with the one facility. Let the contractor come on the ground. As you can see, I think we have more development. Poorly performing districts. I think this was those years. We have less personal business. Colleagues, please keep us stand up. This one here, my leaders, when we came here to the region, if you want to look for KARAMOJA, you start from where? From the bottom, there was one that, there was one of districts. You start from down there, then you come up. So our district were in the last step. In 2020-21, continue broke the record. We showed them that, this thing cannot happen in KARAMOJA. We were number 4. Then now, we shared experiences. Now, other district, last financial year, no, the other one, 22-23. We had how many districts in top 10? 4. 4? 3 districts. Now, back and home, there are 2. So, with no district below the first, I think the last was number 72. 78. So we are not there just not doing anything. But we did not do this alone. Support goes to you, the leaders, for your political will and support.
Doctors, conclude.
Yeah, it's given all possibilities now. Emergency preparedness. Now we have moved. We have launched today the Regional Emergency Operations Center. I was discussing with somebody that the next step is now to move to popularize the emergency preparedness in the districts, and then the gap will be now the budget for preparedness. So it is something we are working on. Immunization coverage, public health immunization last year. If you look at the map released by Ministry, all of us are in category, the region is in category 1, green. So that's another the issue is here. The next one, the issue is big for family planning. We are struggling. And if we start discussing family planning here, it may take 2 days. So it is something which we need to get back to our districts and talk to our people that it is no longer business as usual. We need to look at the number of the children we need. Ambulance services, we are actually here this week, we were located ambulance in Kaba, we are waiting for it. Then those who are not nationally, I hear you also crying that some 200 billion was in from ambulance to another thing. So we pray you get the money to give us the ambulance. Blood donation services, these are also another area we have. Now we are 2 teams. First startup. What did you do last week? Yesterday. What did you do? Give him a microphone. This is leadership, good leadership. They donated the blood. I saw them lying like this with their arms stretched.
As a district, we started from the top. I'm told the fish to give it from the head. So we started from the top. The crown was number 1, the chairman number 2, the HO number 3, all heads of departments. Today, we are targeting at least 50 units of blood
to be picked from Nagalatum. Thank you.
Let's clap. So, which issue will be next? You know, we're not being recorded. So, please, let us get mobilized our community. So, let's not collection center here. So, all of us, you see all of us up there, all the mobilizers. Let's go.
Presenter time.
Latrine coverage.
1 minute time.
Chair, when we were in the preparation meeting, I raised an issue of giving 2 areas big time. Have you seen the organizers' chart? Please, I talk to you about this. Yes. Speak the review of JRM and the balloon this time because that is the backbone. 2, the next one is presentation of the brigade performance. The rest you can learn about those 2. No. Because it is why we are here.
Okay, conclude.
Yeah.
Okay, conclude.
So, the free coverage. This is also another thing, the huge partnering. When partners support, when partners, those who are difficult in the latrine, when partners go away, start education. Today you declare a village open education free, tomorrow people are getting out. So, this goes back to the leaders, so establish underlying issues, grab, support those projects in the problem. But we need, you know, when I grew up, I found that in my area, they call it biology. Mother is here, mother is myself, yeah. Biology. Do you know how it came about from the biology? So, the biology in biology were 2. Each house on Balab at least 1 acre of cotton. And then Balab and latrine. Those 2, if we don't have, we will travel. So why can't we go read? The biology, it is not like ordinary. The council, am I right? Yes, if council can operationalize the biology. No, sir. It is ordinary which needs the Solicitor General, which can take 2 years. But the bylaw, you raise it in the floor of council today, tomorrow it is operational. So why can we adopt the best practices? And so this one we are going to carry forward, but we need more aggressive action here. It is next, before the chair gets give me another one again. So let's think on what to do on bylaw, but we are there. It is finished. Huh?
Yes.
Let me see with my eyes, Thomas.
Now, we say this presenter give me a nice clap. Asante sana. Yes. Please, you can come, then you can pick some issues. Just a minute. Members, I think, shall be briefed for the issues raised so as the members have another session. But of course, the presenter has got very, very good. Lady members, these are very issues. Information to leaders about health, especially towards the appropriation of funds. Hospital status for districts versus local population of 500,000 people. Needs what? It needs what? Further affirmative action. The biggest challenge the commissioner, human resource. Human resource, most of the facilities have no human resource. A BIM has only 2 doctors. 2. 1, 2. The hospital, apart from Moroto, is a BIM, the hospital. We also have issues of members. when a partner gives an ambulance, a partner supplements government efforts and service delivery. When a partner gives an ambulance to the hospital, the government can't give an ambulance again because the partners support the government. So when they give, we count on that. I saw this when I followed up after the vehicle in the Abima, that I got an explanation. All that the commissioner will talk about our ambulances have not been equipped. You give us a highlight, we have a slot for it as a closure. Would also use that in your remarks, throw some light on the Italian law. It has been a long song. A long spell people around here. It will be a different story. Throw light on it. On issue with security members. Yeah, we have improved. And we are there to go. Partners, when this invited for meetings, ensure you turn up. Some don't turn up actually. Or others delegate their staffs of low cadre that cannot engage and they take a decision. They will refer to come and report to the main center, which is not good. Set someone at the managerial level who can take a decision within the session. Then of course, the budget for the operational center, Dr. Semyo told us that the budget is there, the money is there, so we shouldn't lament. Thank you. Those are issues. There's Chairperson Kacheriboy. Kacheriboy, the president, you have remained there. Hey, okay, come.
I want to, first of all, appreciate the organized strong discussion and engagement. Very key that we are discussing issues that will propel the national children of KARAMOJA forward. And I must also appreciate the previous presenters, and particularly the DHO of Otido for being honest. My focus would be, where is the commissioner here? My good brother. Don't get hurt with the things I'm going to say. I will say are the facts, but deliver them to the Ministry of Health, they are going to say it. Number one, chair of the session. It is very heartening that in Uganda, the people who sit in Kampala to discuss how to allocate resources to Uganda favor against language. I was in good for your gift committee. But your district, over 15 projects in one district. Lira, over 10. And very many others. Why does that happen like that? It is because the Commissioner of Health Service Infrastructure comes from there. The Minister of Health comes from there. That's why you find in a Choli region, each district has about 5 to 7 health center tools upgraded to health center 3. But in KARAMOJA, not even one. Continue district, 19 sub-counties, 7 sub-counties without a single health facility. But we are people who are in Kampala, the Ministry of Health, who monitor our health services are being delivered to the children of KARAMOJA. I have written a lot of letters to the Ministry of Health Commission to the extent I am tired and sick of the Ministry of Health because they are not contribute to the failure of the president. I will not accept to lose alone. I will lose, the president will lose, the MPs will lose, the RIDC will lose. I will not go alone. I have to go with some people.
Thank you, Chair. Thank you, Chair.
So,
Chair, conclude. We have another session.
So, issues to do with it. You are right. I want to raise this matter so that he captures issues to do with weight. For me, I can tell you, if you are not going to get Botology Hospital, wait, withdraw the hospital. It's very bad for you to have a Botology Hospital in the name. That's what the sign was. But human resource is not there to offer the much needed health services to the people of the district. You people are putting health facility without giving us money. Why? I mean, it's a traditional hospital. How can a whole like this here who is sharing this meeting? You cry. But I can tell you here, if you go to hospitals in Nacholi, in Lao, in other regions where big shops are, those hospitals are very good. Human resources is replaced, but you come to KARAMOJA because no son of a peasant is at the Ministry of Health, no son of a peasant is a minister, no son of a peasant is the Commissioner of Health Services Infrastructure. Good services can never come to KARAMOJA. As a result, I am waiting, we are moving towards election. The president will come to the district, I will tell him, the people who want you to go home are the following. Ministry of Finance wants the president to pay. Number two, Ministry of Health, a master ministry responsible for any system strengthening in Uganda. You have failed the president of Uganda. Number three, the Ministry of Public Service to mount the pressure of the Ministry of Health and Finance to release money for us to recruit. They have all paid the president. The Ministry of Local Government, they have started on a job to wake up the Minister of Finance, Minister of Health, Minister of Public Service. Those four will make the president lose votes in KARAMOJA. Minister of Health, Finance, Public Service, and Local Government. We cannot do like this. Ambulances have reached all this long time ago. But when they came to KARAMOJA, you are telling us you are still fixing them. How will you fix others and let the KARAMOJA be fixed?
Chairperson, the message has been reached. I said, the conference has been allowed with the presenter.
You look at the Tagalan, you told us that I have been following together with Chairman and my counterparts. We have been following this of Tagalan from day one since we were elected. They say Aliwa has come out. What's happening now? July, construction will begin. Are we in July? They told me in Kampala in July, there will be armed on sites. But we are in August. Tomorrow we are going to September. Italian projects are not kicking off, and that has made KARAMOJA to remain behind, while other regions are benefiting. We shall not accept that. KARAMOJA is part and parcel of the NRA. KARAMOJA is the NRA. Commission, I'm telling you this, don't be the members. As himself, we shall take a person of our problems. We must be part and parcel of eating the national cake with other regions. KARAMOJA must be on the table of planning and eating. Yeah, if you are giving Lao, give KARAMOJA. If you are giving Lacholi, give KARAMOJA. If you are giving Western, give KARAMOJA. If you are giving Sebei, give KARAMOJA. We cannot be given the next
Also, we invite the next presenter, chairperson questions on the demand. The commissioner is going to be sorry. Commissioner, you make your comments for the closure of those issues. Allow me to invite the next presenter, Madam Becky Achon. Madam, yes, she's going to be brief. Allow her to make her presentation. Madam.
On the emergencies, maybe a commissioner, you need to follow this for KARAMOJA. While presenting, there was nothing mentioned about hepatitis B in this region.
She noted the commissioner taking note of that, you come up with that. Thank you.
Good afternoon, everyone. My name is Becky Achon. I work as the senior I will be presenting the annual performance. You can allow me to take this a bit. So, this is a presentation outline. I will make it This map shows the distribution of health facilities in the region. And you can see how scattered and how distributed they are. We have more of the health center tools highlighted in yellow. And then the health center is, each district has either a general hospital, a health center or a regional referral. So this is the population of KARAMOJA. The 2023-2024 population is for the 2024-2025 population is the census population for the region, where we have about 1,450,838 persons. And these are the different categories of people that we serve in the health sector. So during the financial year, we registered a 7.2% improvement in OPD per capita utilization, where Moroto hit the target of 1.5 per capita utilization of OPD. And then we registered an increase in districts of about 44% of the districts registered an improvement in the financial year in OPD attendance. We still registered gaps, very low attendance in Abilato and Amuda districts of 0.7 each. And then when we look at the top 10 causes of morbidity in the region, we get to see that malaria is still a very high leading cause of illness among the general population in the KARAMOJA region. And we also see among the children under 5, malaria is still a leading cause of illness among the children, followed by upper respiratory tract infections and acute diarrhea disease, then pneumonia. Looking at the top causes of mortality, we still have malaria as a leading cause of mortality in the region for both the general population and the children under 5. And then followed by, for the children under 5, we have neonatal conditions such as neonatal sepsis, septicemia, upper respiratory tract infections, and then also malaria still being, and then premature as a condition that requires management. Then tells us a lot about management of the newborns in our health facilities. Looking at the burden of malaria in the region, we still have a very high positivity rate of above 30%. Our target is to have a positivity rate of less than 30% of the total cases tested. But as a region, we are above the 30%. With being recording a very high number of cases, Cotido and Mapiriprid that have up to 50% positivity rate, literally implying that for every 10 persons who come who are tested for malaria, about 5 people turn out to be positive. So as a region, we still have a very high burden of malaria. We now go to maternal child health services, where we are looking at the trend in antenatal care services over time. We compare the last 4 financial years. Generally, we had an improvement in the coverage of antenatal services from 80% in the year 2020-2021 to 85% in the previous financial year. And when we look at progress across districts, we basically see an improvement in all districts, except for Kabul, that registered a decline. We also had Napapiripirit and Napap district registering a decline. From, for instance, Napap was 98%, it reduced to 92%. And ministry recommended that it's very important for every mother to come early enough for antenatal care services within the first trimester. This has also increased over time, where in the 2020-2021, we had 36% of the mothers attending antenatal care in the first trimester, but eventually we've seen an increase up to 45% of the mothers attending antenatal care in first trimester. Ministry targets at least 40%. This improvement is attributed to a lot of advocacy within the region, but also there has been a lot of screening at the outpatient department to identify these mothers early enough and refer them for the appropriate services at an early time. And then when we come to attendance at fourth antenatal care, we also registered an improvement from 44% to now 53%. We target at least 60% of the mothers attending at least 4 antenatal care services. We also registered an improvement as a region, but also some districts did, except for Napapiri Bridge that reduced to 39%. We also registered a low attendance still in Amudat district, sure as depicted with the red. Then when we assess the proportion of mothers who come for antenatal care and are teenagers, those are teenagers from between 10 to 19 years. 13.6% of our mothers at antenatal care are actually teenagers. And in the last financial year, we registered an increase of 0.2%. Amudat registers very high teenage pregnancy rates. This could be attributed to the culture in the district. And we also had Kabong district registered the list, and Abim district coming second in the rates of in having high teenage pregnancy rates. Uptake of maternal services by the pregnant mothers. When these mothers come for antenatal care, they are offered a number of services that are listed below. So at least 97% of the mothers who attended antenatal were able to know their HIV status. 94% had a syphilis test, and we had a positivity rate of 2.5%. Hepatitis B, we had 76% of the mothers screened, and there was a 3.1 positivity rate. Anemia only had 18% of the mothers having a test for anemia, and 13.5% of our mothers were found to be anemic. 85% of the mothers received a long-lasting insecticide-treated nets. 71% of them received iron and folic. 39% were dewormed, and ultrasound was at only 12%. Now, for ultrasound services, these are only offered mainly at high-level facilities, health center force, and above health center force, general hospitals, and regional referrals. And then a few facilities were supported in the region to also offer ultrasound services to the mothers. The same applies to testing for anemia. Not every facility is able to because of limited stock of kits. Antenatal institutional deliveries improved to 64% during the financial year from 59% in the previous years. We basically see an increasing trend in institutional deliveries across the districts, except for Napapiri Bridge that registered a drop by 80%. The district that improved the most was Nabilatuk district, of up to 24%. As a region, we registered a 6% improvement. Here we see at the different schedules that are offered, looking at the 6 days, 6 weeks, and 6 months. What we see is basically postnatal care in the region across the periods, with 6 days scoring at only 33%, mothers coming for antenatal care. Come at 6 weeks, that is at 48.9%. This is also because of the range of services that are offered during the 6 weeks attendance, including immunization services. So once they bring the child, they also accompany them with the different services. At 6 months, we are only 21% as a region. Maternal death, we currently have, as a region, we are not doing very well with the maternal death rates. We are still above the target, 5% as per the last financial year. Over the years, we kind of reduced. So in the last year, we were a bit lower, but increased during this financial year from 33.8% to 71,000 but and the highest maternal death in Moroto. This could be attributed to having the regional referral. Registering high maternal death at 138,000 and Amuda district. The low rates were registered in Pareta, Abi, Kabong, Kotido, with Nabilatuk and Ahapiripirip district reporting no maternal death in the year 2024. So what we see, when we assess our maternal death, we see that 48% of our mothers actually died due to postpartum hemorrhage, that is bleeding after giving birth. And then 26% was due to preeclampsia, that is, I think, high blood pressure in pregnancy. And then the lowest being the PH and hemorrhage. By age, we see we lose a lot of mothers who are 15 to 19 years. So as a house, we need to advocate to reduce teenage pregnancies. These are mainly due to biologically related factors, that these mothers are still young and may not be able to give birth. So we end up losing them, especially if they choose to give birth from home. Because such mothers need specialized care at the hospital facility. Looking at perinatal death, as a region, we have reduced. Previously, we were at 17.3 per 1,000 live birth, but now in this financial year, we are 14.4. This reduction is mainly attributed to partner interventions around reduction of maternal death in terms of training and then also advocacy, mobilization of mothers who attend antenatal care services and also receive delivery facility services at the health facility. We had 96% of fight and 82% were reviewed. Key to note is Napa, Moroto, and still have very high perinatal death because the WHO targets are 12 per 1,000 live birth, and as a region we are still at 14.4, which is still high. Looking at the probable causes of perinatal death, first is that the highest proportion of our perinatal death is due to fresh stillbirth, followed by early neonatal death at 0 to 7 days. And perinatal death are mainly caused by birth asphyxia, attributing up to 42% of 24% of the perinatal death, and then intrauterine hypoxia. We also looked at the uptake of our family planning services as health and preventing high mortality. 3%, the 0.3% improvement from the previous financial year of uptake of mothers 15 to 49 years receiving family planning services, whether short-term or long-term. And the highest district with the uptake of services is Abim at 12.3%, and then Moroto at 19.5%. The least being 5.4%, Nabilatuk, Otido, and Amuda districts. And then, so we still have a gap of up to about 275,000 mothers who are supposed to be receiving family planning services and are actually not actively receiving them. Sometimes it's either due to unavailability of the service or basically the myth that surround the family planning services. When we look at the mothers who have delivered, we expect that when the mother delivers, there is some child spacing over time as the other child grows. We saw an increase in the number of mothers who received family planning services from 3,685 to 5,011. This is also still attributed to advocacy in the community around family planning and use of family planning services in child spacing. Couple years of protection basically looks at, like here in KARAMOJA, how many couples are protected from unplanned pregnancies or unplanned childbirth. So what we see as a region, we have up to 24,000 couples, 24,538 couples protected from unplanned pregnancies, with the highest number being from Moroto at 5,947, and the least being in Amuda and up at 1,992 and 1,657. We also went ahead and looked at the kind of methods that our clients in the community or our mothers are using. The light green shows short-term methods that are mainly pills and injectables, and then the orange is the condoms, and then the green is the long-term methods that last about 3 to 5 years. The blue is the natural methods, and then we have the permanent methods at the top with either red. Now, what it shows that most of our mothers prefer the short-term methods, that is the light green and the orange, and very few go for the permanent methods. And actually, we have a larger group of mothers going for the natural method of family planning. Looking at the uptake of our immunization services, we looked at the different antigens that are offered. So as a region, we still have gaps around BCG. BCG is for prevention of TB in children. And then oral polio is for prevention of polio. Oral polio and BCG are given at birth before a mother goes home. So we have a suboptimal performance in the BCG and oral polio. Our national target is at 90%, but we have this performing at 75% in the last financial year and 73%. Rotavirus scored fairly well. That is for prevention of diarrhea in children. At 94% for the first dose. For the second dose, we had 87%. And then measles rubella we are recommended to have 2 doses. So for the first dose, we are at 92%, but we have a gap in the second dose, where we have only vaccinated up to 29%. So this puts us as a region at a risk of having outbreaks, especially for measles, just like we recently had outbreaks in Moroto, and we could easily have this in other districts as well if we do not up our immunization services. The red flag categorization looks at, the red flag is reach every district, reach every child. We categorize uptake of immunization services by DPT 1 and DPT 3. So earlier on, Dr. Chara mentioned that as a region, we are currently in category 1. We improved over time. Previously, we were in category 3 for the previous 2 financial years, and subsequently, we have moved to category 1. This has been registered progress in many districts. We have an APAC improved, improved. A majority of the districts actually improved. It's only Nakapiripiri that has still remained in category 3. And then we have Karela in category 2, and then Abim in category 2. So we can still improve the immunization services, but also so what we see here by the different districts, there was also improvement in micro-planning supported by the different implementing partners that saw a number of districts map out different outreach sites that were not previously being reached. Also integration of services, for instance, with the seasonal malaria chemo services led to the increase. And
5 minutes to us.
What we have is the 0 dose distribution. These are children who have not received any vaccine. So we see an improvement over time. The first map shows what it was in 2021-2022. And then in 2023-2024, we now have one district in red that still needs to be supported to be moved to green. And then we have a BIM still in yellow, and Moroto, Arena, and Amuda also still needs have a few children who have not been reached. Uptake of vitamin A and first and second dose also improved. First dose improved to 109 and second dose to 114% in the last year. The warming for children under 5 years, our target is 90%. Also registered an improvement across the districts. All districts were in green, except for second dose, where Nakapiripiri and Moroto are still below the 90%, and then above. We for every child who comes for nutrition service, OPD attendance, we are nutrition status to help with the timely identification. In the general OPD, 80% of the patients were assessed. Malnutrition rate was at 9.1%. That is on the first graph. And then on the second graph, we see for children under 5, where 85% of the children were assessed in the last year, and 19% were found to be malnourished, which is very high for the region. For the children who get admitted to the different programs, the supplementary feeding program had a cure rate of 71%, which is still below the 75% target, and a very high non-response rate of up to 16%, attributed to sharing of feeds and also big families in the community that share the little feeds that are given to the malnourished children. At outpatient therapeutic care, we had a cure rate of up to 77%, still with a high non-response rate of up to 13% and a high default rate of up to 10%. There's also a lot of misuse and abuse of the therapeutic feeds in the community. For the inpatient of the children are successfully treated. And however, we registered a high death rates in Kabong, Karenya, Kotido, and Moroto among those who are admitted. And some of the causes of the death are due to hypothermia, but also we have a lot of children attendants who escort fellow children to the facilities. Looking at our performance in TB case detection, we performed fairly well at 79%, with the high-performing districts being Kotido, Kabong, and Abim, whereas the least were Nabilatu, Moroto, and Amuda districts. There has been a reduction over time in the proportion of persons who have been detected. For children 0 to 4, 97% of the children were detected of the total targets, the highest being in Kotido. So we see a lot of TB in Kotido for both the general art people and our children at 251%, followed by Kabong at 144%. And this trend has also decreased over time. And then looking at the treatment outcomes by health facility level, we see that the treatment outcomes were fairly well. The health center breeds had a high number, almost 50% of the patients identified, and then fair treatment outcomes were registered and health center for levels. Whereas the regional referral and maternal hospital registered high death rates of up to 5 and 7%. When we look at it by district, at least all the districts scored a treatment success rate of up to 90%, which is the national target. As a region, were 93%. And death rates were controlled up to only 5%, the highest being in Napa and Abim districts at 5% and 4% respectively. When we look at trends of drug-resistant TB, we see an increasing trend, with the last quarter of April-June registering up to 37 persons with MDR-TB. And the map shows us the distribution of multi-drug drug-resistant TB by district, where the green shows high numbers, the yellow shows a few numbers between 1 and 2. So we have Nakapiriprit, Nabilatu, Kotido, and Kabong having very high cases of multi-drug resistant TB. But also key to note is 90% of the drug-resistant TB cases are persons who are poorly managed for the drug-susceptible TB. Enrollment on TB prevention, this is for persons who are in contact with TB patients. I'm mainly looking at children below 5 years. We had at least up to 91% of TB contacts enrolled into TB prevention. The least enrollment was registered in Amudat at 68% and Apilpiri at 64%.
Present
Progress towards the HIV AIDS 95-95, a global target. Currently, we have up to 104% of the total target know their status, either HIV negative or positive. For the persons who have been identified, we have all of them currently on Act. And then only 92% of the persons were suppressed. Some of the poor reasons for the low suppression is the stigma among patients, and that leads to poor treatment adherence. The table basically shows us treatment enrollment over time. As a region, we currently have 8,275 persons actively taking antiretroviral therapy. What performance I'm basically going to summarize around households with peak latrines. We are having up to 24% in the region. And then households with improved latrine coverage at 31%, households with hand washing facility at 45%, and then ODF, open defecation free households are up to 19%. Human resource for health, we have up to 60.1% level of staffing in the region, with Karela having the highest levels of staffing at 80%, and AMDAT, the least, at 46%. So, so we have a presentation, a brief presentation on medicines.
Members, allow the presenter to conclude. Don't hijack.
Someone will briefly take us through the presentation on medicines, and then we'll finally look at the league table for the region. Thank you.
Thank you so much, Vicky.
That for the presentation. But be mindful of time. Check out your watch. Yes, be mindful of time.
Thank you so much. I'm called Samuel Becker Queer, medical logistics specialist. I'm working with the local partner, Mecca, and standing in for the regional pharmacist, who is the lead of the supply chain technical working group for KARAMOJA. And this is a snapshot of supply chain management for the region. Supply chain is briefly everything that we do to see that we have the commodities to offer quality services. And that takes a lot of activities, from procurement planning, ordering, receipt, warehouse management, distribution, and use. And what we are seeing here is a summary of the activities that we do to see that we have the commodities made available to our end user, and that is the client. So the first activity to start with is ordering. We all know the commodities are at the national warehouses, but based on order from each facility. So it's a requirement that every facility places an order to national medical store, joint medical store, such that we then will receive the medicine. So what we can see is for our region, we've had 100% order submission rate. So all our facilities that we support public health were able to submit orders to national medical store. And then looking at the PNP sector, still we've been able to achieve 100% submission rate of orders. So with this, we then know if national medical store, joint medical store then delivers to the expectation, we should have adequate medicine flowing into the region to meet the needs of our health workers and the patients. Now, the next item is the SPA, that is the supervision. We As a region, we try to put a tap on supervising activities within supply chain management, looking at the so many quality indicators, achieve quality commodity management. So 83% present the performance of supply chain activities in terms of quality. So we have a quality gap of 17%, and the ministry's target is 80%. You can really agree that for KARAMOJA region, we are doing supply chain in the most efficient and cost-effective way. Now, the 83 is based on external supervision. It's based on external supervision where external actors come and do the assessment. However, the external is based on funding from partners. Now, the ministry devised an internal supervision tool, which is the digital supply chain self-assessment tool. This is the owners of the facility to take charge of their activities, identify gaps, and also come up with intervention to improve supply chain management. Now, the enrollment at the moment for high-level facilities, which are 11 facilities, general hospitals, and regional referral, is at 100%. Now, the direction for us is to take this down to a level of Center 3, such that we have facilities take charge of their assessment and quality improvement in terms of supply chain management. We've heard from the previous presenter that globalization is almost another health risk, and you agree with me that we have the advent of internet and computers taking shape in the country and nationally. Now, we are not left behind in terms of supply chain management. The move is currently digitizing community management from the national level up to the lowest level of care, and that is National Medical Store to the level of Center 2. At the moment, we can say 30 of our facilities are having computers installed with software to manage stock. And of the 30, 61% have shown consistent use of the software. And this is a very good progress toward visibility, transparency, and accountability for the medicine that we receive in this region. Then next is reporting. You'll appreciate that supply chain processes information. The data is the driver for commodity management in our region. So the 93% represent quality data that is submitted for commodities in our health facilities. We have a gap of only 7% quality, and we are working towards see that this is breached. And then lastly, I said the overall goal is of supply chain is to provide commodity security, and 74% is what we perform. This means that out of 10 probably prescription, we can afford to give 7. The national target is 95. We are moving towards seeing that we should be able to achieve 95% per 100 commodity availability. So that is an overview. Quickly to go into
wind up.
Yes.
To one overview. Conclude.
So just doing commodity reporting, because I said commodity data is the vehicle of supply chain. In July 2023, we had equality reporting of only 74%, and availability of commodities was standing at 56%. Currently, in June, 1 year after, we moved to 93% quality reporting with availability of 74% regionally. And
The question now is, we have achieved reporting, visibility, and availability. Now, accountability should then come next. With the visibility, we should be able to be more accountable to the bodies that receive. Just go to the next thing. Yes, please. I have reporting improved, visibility improved. So what? So the data use becomes key then. And this has been made possible by the Ministry of Health by designing a system, a dashboard that automates analysis for the commodities that we report nationally. This is just a snapshot of one district, that is Abuja. When you log into this dashboard, you select the region, select the district, and any commodity that you want to look at. Now, we just quickly picked cotton, the metal refractory, and you can quickly see that availability of cotton at Amuda's district is at 100%. While of the report provided, all facilities were able to submit the report. The next time we're looking at the quality. Even when they have submitted for the report, we still have batches of quality issues. But then we can see that visibility is at 100%. You can see we have slight overstock in the last column. The yellow represents understock. All the group shows that all the facilities are overstocked, and then there is also one understock. So this is just a snapshot of the system that has been made available, open access, no password. Anyone can log in and you have a real view of the commodity status in the district. Last slide. So these are just some of the key challenges and mitigation. One is we've had erratic delivery from National Medical Store. We barely witnessed we've had right delivery or a missed delivery for almost 3 or 4 months. We've handled this by distribution using the previous database to identify the overstock, understock, and then redistribute the medicines. Our ask then at central level, there should be engagement to streamline these inefficiencies at national level. Secondly, we've had the challenge with our supply chain human resources. Agree with me, for supply chain, the element factors, some of them are human resources for health, technical and supply chain management, budget, leadership and governance. But we do not have dedicated and well-trained staff to handle supply chain. The more underskilled. So this slide will be made available for sharing. We can go through them later. Otherwise, the call is for all of us to appreciate supply chain, leadership and governance, commit resources to supply chain management, let's do recruitment for a dedicated team to handle health supply chain, and then utilize the data to make informed supply chain decisions. Thank you so much.
Asante sana. This was a 2-in-1 presentation. Next time we try to separate so that not enough time on it, because again we are coming back. Members, is it so we go to another item? Come again? Democrats, that's what? What time? How many minutes? 2 minutes, please.
Okay, so let's scroll. Just scroll and we go to the recommendation. So we conclude. We have have the league table, we'll flash later. But we conclude, these are some of the conclusions, that in the region we still have a high burden of malaria, high maternal and prenatal death, low levels of staffing, and then we have increasing trend in antenatal attendance. All maternal deaths were reviewed and notified a positive trend in immunization, a coverage. And we recommend the following: more technical and financial support to the underperforming districts to also bring them up to speed, more training and mentorships to address the causes of maternal and prenatal death in the region, especially skilling around newborn care to arrest death due to asphyxia, strengthen follow-up of TB cases to reduce loss to follow-up, more psychosocial support. We also looked at improving access to health services. Currently in the region, 22 sub-counties do not have a single health facility. And then for some sub-counties that have, they only have a health center too, as the only entry service point. And then 70% of the health facilities in the region are health center tools, and we therefore recommend that that should be an upgrade.
Asante sana.
So we have a
When you say Alakaranoy, no, next time present, organize your slides well, okay?
That's right. So what we have here is we have two league tables. The one for finance will be presented tomorrow. This is the first one is the annual performance league table, which basically assesses up to about 13 indicators. It's quite small. We should have presented it in Excel. But we have the 9 districts where we have an ability coming in as the first scoring up to 85. Thank you. And then when we look at the quality improvement, when we look at the quality improvement, we assessed up to about 8 indicators. That is the availability of the regional quality improvement committee, the district quality improvement committee. We also looked at HLPLP scores, and Nakapiripiri came out first in the region. Thank you.
Members, asante sana. We are towards the beginning of the closure. I would request the members we raise our hand for long before we can resume for towards the beginning of the closure. The main one will be just the commissioner give a response on our issues. I request that you raise your hands up, one hand, okay, both of them. Back a bit, slide it back a bit, in front a bit. Up again the hands. Invite someone to come to you. Invite. Breathe in, out, in, out. Let's resume our seats. Another introduction, the other one is going to awarding ceremony, the best performers, recognition of the best performance. And I will invite the director, the doctor here to give us the ranking of the best performers, and then we shall give them what they are supposed to do. Then after that, the commissioner will make the closing remarks.
Thank you so much, Habib. I think you've seen the league table is very fair and clear. So most of us are able to see the award winners today. And so allow me welcome the commissioner, the hospital director, to come in front. There will be awarding districts, I think, winner. And then the representation of the council. Yes. Do you have? But I think we are going to the one district, so. And then we have, yes, I think the representation from partners, and also the UN family, one person, and then from USID. UHF team, please come and represent the partners. As we reward the best district performance. And today, ladies and gentlemen, as per the league table, we're able to see there are categories of districts. And as we look at this, I think we are starting already with health facility in terms of health facilities. We looked at health facilities that are capable of doing all services, and this is at a level of CMOC size. That is Health Center for General Hospitals and the regional hospitals. So they were subject to all those qualities. Our electoral commission put all those standards together, and we are seeing that St. Kisito Hospital Matan has the best performing health facility. And so we would love to see the supporting, the medical superintendent, the supporting DHO, and you can come along. Yes, because I know your team is the pack team. Make sure you come and you have a handshake with the partners. And I think the cameraman, please get ready and make sure recognize MBS. Make sure you announce this that St. Kisito Hospital Matan. You have a handshake from the partners, and then come from the other side. Yes. Yes. And then Commissioner, yes. The Commissioner will give the award. Make sure you have a good handshake. And the cameraman. Yes, remove it out. Let us have a look at it. I know the packaging is good, is equally good, but you should be looking at the award itself. Yes. You know, check the side. We must see whether it's cold or to see whether it's strong. Yes. Let us clap our hands. Applause for St. Kisito Hospital, Matan. And let them see the ball. Yes, let us appreciate the Kisito Hospital, Matan. Thank you for the good service delivery. There are a number of indicators, but we know is that many patients are not dying. There is a lot of admissions, but the rate of death is very low. So it means the quality of care has been quite exceptional. Thank you so much, Yes, yes, we also have to recognize the district with the best health service delivery. When look back into the health, please put the league table. Put for us the league table, and we see health service delivery, all those health service indicators were put together. I think all of us can see what is the planning center telling us. Yes. Wow, I can see Nabila emerging the best in health service delivery for this year, according to the standard of assessment. Allow us welcome the DHO and the HOW and the RRH, the LP5, the HOW, the DHO. This is a team. It's a team. So, team clap for them as they come. That's a great performance. Yeah, tomorrow they are going to tell you what they have done, what others have not done. So we have some sessions for them to tell us what they have done better. Make sure the accolade comes out and they have a good look at it. Cow Nabilatum, we said, who is the cow? We also want to thank him for the great work done. Yes, yes, thank you so much, Nabilatum. The total score there is 84.5%. It is more than a margin of 50%. Not like our national elections. Cameramen, take good photos and good smiles. Yes. It's not easy to perform, and it's not easy to supervise. I mean, it's snowing, hunger, things, water, we still have facilities that are doing fine. So let us celebrate Nabilatum. Ladies and gentlemen, we take note that quality improvement is one of the key initiatives of Ministry of Health, and we are integrating it across health service delivery. And it is a measure that will lead us to improving health services across. So those key gaps. And we also assess the performance, district performance, according to quality improvement. And ladies and gentlemen, we are seeing that across these indicators, the record, I know attendance to record Nagapiripiri in the house? Yes. Wow, thank you. Yes. They measure very many things, and in the end, is Nagapiripiri command to the best in quality health improvement in table. The DHO, how the different district stakeholders, you're most welcome. Yes, please give a handshake to the stakeholders. Let us clap our hands for Nagapiripiri. Now, they are doing well in quality improvement. There are some indicators I've seen where we've had hassles in Nagapiripiri. So they are, that's why you see each district is doing well in one or the other. Yes, let us celebrate Nagapiripiri for that. Yes, cameraman, make sure you do that nicely. Ladies and gentlemen, this has been stimulus for this. Thank you, Nagapiripiri. They have been implemented in 5S, CQI, and then Kaizen, and many other things. TQM, our original QI for person understands things to the best. Thank you so much, Nagapiripiri. Yes, I know we have second part. We also want to recognize the regional oversight, definitely. The regional referral hospital, we want to recognize Moroto Regional Referral Hospital for the regional technical oversight, making sure we receive all this funded, and Moroto Regional Referral Hospital. We want to recognize you. The reason why we are here, all the stakeholders, support provisions, all these districts are performing well because the consultants. There's been technical guidance in terms of health service delivery. Please, you need to be recognized for performance. And definitely, when we are recognizing the regional referral, we also recognize all partners because there's all the partners in the house. The regional referral cannot achieve it without you. So, all the partners in the house, you're all in that same category. So, you all deserve to be. So that is our partners, the regional referral hospital. Thank you so much for supporting the region and making sure you keep us at that pace. Now, there are two awards that I want to interest us, and that I think, Chair, we want to refer it to tomorrow. There are two awards because our talent center needed to first verify. And one is the district performing well in health financing. There are lots of indicators that are still being put together. And that one we will award it tomorrow. And I think we will recognize that tomorrow. And then I think also there is the other aspect of the performing district health officer. We want to reward the DHO because it's health. So those two awards, we will reward them tomorrow. We want to define it tomorrow. But it's because we have shown display to us performance and show that every single year we want to reward this culture. And hopefully we want to see that
This league table does not heavily differ from the national league table unless they change indicators. The indicators used there were benchmarked from the previous one. So it means maybe indicators which are, but at least for us as KARAMOJA, we want to appreciate the districts that have performed well. Thank you, Nakapiri. Thank you, Nabilatu. Thank you, St. Hospital Matan for the great performance. And we want to look forward to financing. Northern KARAMOJA, we want to come for you. I think I'm beginning to see the trends have been a bit around the south. So what is happening, those are things we want to, we will discuss tomorrow. So thank you so much, our guests, for appreciating this. And without spending much of our time, allow me also welcome our guests to come and give us the closing remarks for today. So that and also you'll be able to answer quite a lot of questions that were raised. There were very core concerns that came across. I recognize the LC5, Cotido, and the rest of the concerns. Please, you're most welcome.
Yes, let us appreciate our MC. And another one for our chair for this session. I'm very excited. Why? Because of these final presentations, the performance. The performance in this region has improved so much. For those who have been around for some time, most of these indicators will be in local colors. But now the indicators are pointing to life. This is great. Let us thank all of you and let us have a warm hand. It's a big contribution. And I want to tell the leaders, the political leaders, the technical leaders, who may not necessarily be the health professionals, that you have done a big contribution. And I specifically address my brother from Cotido that don't worry, you are going to be voted back because this is showing a change. So don't have big worries. You know, we tend to talk more about the negative and forget the positive. But there's a positive change in the KARAMOJA region, and everyone contributing to this. Feel happy with that contribution. Then you say there is a gap here. Let me push for it, and we shall move, we shall deliver, we shall be there. So my brother, feel very comfortable even when you talk to His Excellency. Indicate the positives. Start with all that. Then you can come to the small other things which we are going to fix. Thank you. Now I want to respond to some of these issues which arose. Of course, as you know, the issue of each district having a general hospital, His Excellency the President pledged this. But when you heard from Dr. Acha about Cotido, in order for, we don't just only do infrastructure, you must balance the things which are going to move with that infrastructure. A general hospital can be constructed, but when you are doing the construction, ask yourself, do I have money which is going to run it? It is called non-wage. Do I have money for medicines and supplies? Do I have money for health workers' wage? And when all these things are in place, then you say, okay, now I am ready to move. And that is when the hospital becomes a hospital. So the decisions which the Ministry of Health has taken is that this commitment will be gradual. So that's why you see that one hospital will come, then after a year, another one like that until we achieve that target of His Excellency. So let us be patient and know that that planning is ongoing. On the human resource, Abim reported that they have 2 doctors. This is something which I am going again to consult with the center, because there should have been wage for recruitment for this hospital. But again, a request to CAR, when such things occur, let us do quick consultation with Ministry of Health, with the Ministry of Public Service and Ministry of Finance, so that we have a quick answer. Because Abim is an old hospital, I expect it to be well staffed. I was calling the Director General, but we did not have an immediate answer to this one. So when I go back, I'm going to have him address to that. Now, Potato General Hospital, it is absurd and unfortunate that it was upgraded with no wage. That one is not, I feel there must have been a mistake. And whoever called at the ministry is surprised that it was upgraded to a general hospital and it has 24 staff. I will request the district, the letters which you have written to the ministry, let me have those copies so that we can have an engagement, because many districts were getting wage last year. All these which had issues, but at least did not feature. So please let me have those writings, then I submit them to the Director General, who will have it discussed at the senior top management. It is not something usual. Whenever Minister of Health says we have upgraded you to a health center 4, it means there is wage, there is non-wage, there is medicines and supplies. Those things go hand in hand, not infrastructure alone. Actually, we call them the 4. Those big 4, you must make sure that you deal with them before you pronounce anything. So that will be. Then on ambulances, my apologies that those who were handed an ambulance by the Right Honorable Prime Minister, you have not yet received them. That is my problem, partly because when we received these assets, some of them were ready to be given out, others were not. But we wanted to have one function where the Prime Minister presides, so we gave out 116 ambulances. But unfortunately, 34 of them were not yet ready. And I've been promised that within about 4 months they will. You remember the first letter you got from the minister. You were supposed to have got the ambulances, I think around February. Then we extended it to May. We now extended it to September. The reason is that we were in the procurement process for having them upgraded to meet the standards of Ministry of Health. And the discussions and agreements with the different authorities happened to take long. But now we have started the process of the upgrade. I'll be consulting with the engineers and the contractors to when these things will be ready. And then I will request the Honorable Minister to
inform you when they will be ready for picking. But I'm now worried of her writing. Those are 34 constituencies. They will come, and when they will come, they will be at the same level as the others who received earlier. Now, the Italian loan. Since I joined the ministry, I found this ongoing. There were changes in the way in which government operates with development partners, and that change affected the process. Then we went into also COVID-19, which disorganized everything. We are now back on. I've just got an update from the Director General that the phase which is soon getting completed is the one of evaluation of bids. I think I've not yet got the list for the health facilities to be upgraded, but I think there are some 5 health facilities per district which will be upgraded, and after this evaluation process, I think we shall have that actual list. I tried to get to the engineer, but I think he was occupied. I couldn't get to him. But I've been assured by the Director General that that step of evaluation of bids is the one ongoing. After that, an hour, and contractors will be in the district. And then the other thing which in this struggle for survival in a difficult country which has low levels of income, I have learned that it is not good to compare so much yourself with your neighbor. If you get up in the morning and your neighbor is putting on a suit, don't say that I need to put on that very suit. It can be very dangerous. Just get what you have. I need to move. And when you move, you have that success. And I'm requesting that as KARAMOJA will move, let us move and move positively. Mr. Chairman, that's not yours, that is for everybody here. Now, another comment I want to make is on a BIM hospital renovation. I want to thank the management of BIM, if I comment on the renovation, that you agreed with our policy of having one ambulance per constituency. I know you struggled a lot to get another ambulance to have 2, but due to that policy, you managed to help your neighbors, the district of Napak. I want to thank you for that. I think Napak also gives that contribution. Thank you for being good people and accepting.
Asante sana.
The Director General has told me that I submit, I submit the issue of hospital to him for follow-up. So I request that the Chief Administrative Officer gives me that report to go with. And then the other issue was on hepatitis B. Of course, next time in the report, let us receive it. But I want to say that hepatitis B vaccination is ongoing, and KARAMOJA is one of the regions which has been prioritized. I'll be able to get further information, I think, tomorrow, and submit it to the hospital director. The last one is on VHTs. VHTs, we did, the plan of the ministry was to have an intermediary group called CHOOSE, Community Health Workers, community health extension workers, the Jews, who were to be at least paid for that. But the political leaders did not think that that was a good strategy. They had wanted all the VHTs. So the first appeal for resources, at that time resources I think had been mobilized, but due to that political hiccup, that was a little bit shelved, and they started with pilots in some districts. The reason why it was not proper to have all the PhDs was what was explained earlier on. The cost was a little bit prohibitive. So it was decided that let's start with the intermediary team. The intermediary team were like at the parish level, people who are leaders in their villages, they are chosen and they become like the supervisors of others. That is the one which was ongoing. This one of paying, I think the new suggestion of paying them the same as LCs. LCs, they receive, I think once a year they receive some money. Is it 120,000? Maybe I think that should become a proposal even at various levels, because that makes it less costly. The original one was a bit costly because it was a monthly pay, which was I think something like 60,000, and when they calculated it was so much, and it was unaffordable. So I want to thank you, and I want really to say I am grateful to all of you for committing your time to attend. Your commitment to attend as various stakeholders is very important. And as I said before, the analysis here means a lot, because you are talking to and seeing what is happening in the village somewhere. While when we talk from Kampala, we are not realistic, we are not touching the real person, and I feel this is great. And I thank the winners of today, the districts that have won, and the General Hospital Matani. Matani is sometimes referred to as a Pharaoh Hospital, sometimes a General Hospital, but we thank you because you have stood all the time, always performing to your best. Thank you so much. And the Nabila Tuk for leading all the other districts, we are grateful. Now, Nakapila, I was going to, in my statement, I was going to talk about poorly performing districts, but now I had to change because Nakapila was among the three that I wanted to say that please support these districts. But now, in the last slide, comes out as the best quality improvement district. Thank you so much.
Thank you, our DG, for the close of the meeting, final remarks. And thank you, ladies and gentlemen, for enduring up to this time. One of the things, we have additional engagements tomorrow, and we will still be awarding the other two parties tomorrow. So our electoral commission is still doing another additional assessment. Thank you so much, our commissioner, for answering the key questions. We have a lot of discussions tomorrow, and more questions that will be arising as well. Thank you so much. Partners, you can send your the presentations to Vicky for review this evening, and we have more discussions tomorrow. Others, thank you so much. Hopefully, we have signed as per the level of support. I
I know that administrative announcements were given in the invitation letters, and they were very clear. Thank you so much. See you tomorrow. God bless you, and have a safe night in Moroto. Confirm the evening tea. Yes, make sure you take a cup of tea before you go, because we know you're sleeping around, so take a good cup of tea before you rest. Yes, for God and my country.